A very warm welcome to all of you to this new edition of the ICH Journal Club. Today, we will focus on BPDCN and in particular on responses to tagraxofosp in the relapse refractory setting. Building on an important paper that was published actually very recently by Dr. Angelucci and colleagues. And the title is shown here, Real-World Study of Tagraxofosp Monotherapy in Relapsed or Refractory BPDCN. And that was published in Leukemia Lymphoma recently. Together, we will review through this discussion with our top expert in this field, the famous Dr. Naveen Pemmaraju, who is a professor of medicine at MD Anderson Cancer Center in Houston. And Naveen has pioneered and allowed for significant advances in this very rare and terrible condition, I would say. This is the abstract of the paper, and to make a long story short, it's a series of 24 patients. You may think it's a small series, but actually it's a big series. In a country like France, you have per year 30 to 40 cases of BPDCN. So these are 24 patients, median age 68, so relatively advanced age, who had a relapse refractory BPDCN, who received tagraxofosp, and we observe a 65% overall response rate, 9.5 months median duration of response, and most importantly, and we will discuss this with our expert, 10 patients were able to proceed to transplant, and the median overall survival is not reached yet. There were no new safety signals, and we will discuss also this issue. So you can see here the characteristics of these patients. They have received multiple lines of therapies, and as expected, since there's no standard of care in BPDCN in the frontline setting until recently, they got an ALL, AML-like, or even many other regimens. Some of them, 4 cases out of 24, which is quite a lot, I think, received an allotransplant actually prior to TAG. So despite being so advanced, you can appreciate here the response rate, and it's not, it's an important, you have 35% of patients in CR, or 5% CRI, and 25% in PR. And of course, if you focus on the patient who were bridged to transplant, actually, we have 60% of CR. So the take-home message of the authors from this paper, and we will hear from Dr. Pemmaraju whether he agrees or not, tagraxofosp is active in relapsed refractory BPDCN. It allows to bridge many patients to allotransplant. And actually, those responders who reach transplant are really doing better. Safety profile, nothing new. The capillary leak syndrome, mostly in cycle 1, but manageable. The treatment approach is effective even in high burden disease, and it is real-world data, and it's consistent with what we know from the clinical trials that we discussed actually as part of the ICH Journal Club a few years ago. So obviously, tagraxofosp remains a standard option for relapse refractory BPDCN. So I'll stop here and thank you again, Naveen, for joining us. You are our superstar. You've been a great supporter of the ICH since 2018, and we are very grateful for all your contributions. So before digging deeper into this paper, Naveen, can I kindly ask you to summarize, because it's such a rare condition, what is the state-of-the-art diagnosis of BPDCN? Because recently I was talking with one of my junior colleagues, and we discussed a case where, the patient went through all dermatologists, went through the GPs, all kind of specialists before ending in hematology. So I thought the diagnosis maybe is not very straightforward.
Well, thank you, Professor Moti. Before I begin, I want to just take a moment of personal gratitude to you and to the IACH, International Academy for Clinical Hematology program, yourself, Professor Nagler, our dear friend, and many others who, before COVID, during COVID, and after COVID, platforms such as this in the digital space have allowed so many of us, including myself, to benefit, get together, exchange best practices and ideas. So thank you very much to you. You're so modest and humble, but I want you to take a moment to understand how grateful I am and all of us are, Professor Moti, sir. As we begin here in our BPDCN journey, and you've helped so much to develop that on the world stage, I'd like to give a few overview points before we get into the paper. So blastic plasmacytoid dendritic cell neoplasm, a long, unwieldy term. For some of our more seasoned hematologists, the name only crystallized in 2008. So to understand this disease, we must go back to the 90s. It used to be called, some of us remember it as NK cell or NK lymphomoblastic cell. Then it became CD4 positive, CD56 positive, hematodermic tumor, et cetera, et cetera. And so to your beautiful point, this rare entity is not only truly rare, but also misdiagnosed and never diagnosed. That's because the majority of patients present with cutaneous involvement, skin lesions. And so we found in our historical perspective in America and European series, a lot of these patients ended up with the dermatologist, so skin doctors, or lymphoma specialists, or even non-hematologists, as you mentioned. So BPDCN is immature cells of these PDCs, plasmacytoid dendritic cells. So that's the malignant cell. It was thought to be a lymphoma because CD56. Now we know it as a more myeloid disease, PDCs. And because it can affect multiple compartments, it's a confounding diagnosis. So skin involvement makes it rare among blood cancers. These PDCs like to go back and forth, the immune system, skin. 2 is our bone marrow and blood involvement. 3, lymph nodes, and can you believe it, even 4, central nervous system, so a large predilection for CSF positivity. These are the 4 major compartments. In fact, BPDCN can present either isolated or combined with one of those, and in fact, it can present without the skin lesions, making it even more difficult. So I would say anywhere where you have a diagnosis of a leukemia, keep BPDCN in mind. We're in both WHO and ICC classifications listed as BPDCN. And it requires really the cerebral thinking of the clinician, but also the help of either derm or hematopath or your pathologist. The key, if you're thinking about BPDCN, is to think about it in the differential with AML, leukemia cutis, cutaneous T-cell lymphoma, skin involving malignancies, and include the CD123 stain, CD4, CD56, and ultimately, if you can, the TCL1 and TCF4. That gets you to 99, 100% specificity. So Professor Moti, I think that's the background of thinking about BPDCN, any blood malignancy with skin lesions, any pancytopenia, NOS leukemia, and then if you have a CD123 positive tumor, to keep it in your differential.
Wonderful. Thank you. Very clear. And I think this is now becoming more and more helpful. And of course, we need to keep on raising awareness, because obviously, when it comes to these ultra rare conditions that you don't see frequently, it's relatively easy to miss, unfortunately. It doesn't mean you're a good or bad doctor. It's simply that This is how, unfortunately, it works. So, what about the features of the patient? For instance, in this paper that we're going to discuss, the median age is 68, which is quite advanced, if you consider Hodgkin or ALL or other diseases. And we've seen the range can go above 90. So they are like all patients. Usually they have frailties, comorbidities. How can you describe the standard BPDCN patient in real life?
Well, you nailed it nicely. Yeah. So historically, BPDCN has been understood as a disease of older patients. And in fact, exactly as you said, median age 68 to 70 in almost all of our historical series. Two caveats to that. One is it's also predominantly a male disease. This is unique among our heme malignancies, maybe 3 to 1, up to 5 to 1 male to female ratio. Several theories for that. One is that a lot of the patients can have an X chromosome inactivation because of the ZRSR2 mutation that may account 1/3 of the patients. And maybe there's some other biological reasons. So I think that's interesting. But I do want to emphasize a couple of new points. That's the historical expectation. Older, frail patient, skin lesions, comorbidities, maybe not even eligible for transplant. Now, in the modern era, which I'll define as since the approval of the tag in US, so since 2018 and beyond, so almost 10 years, we're starting to see a second wave. I want to emphasize for our viewers out there, I don't think there's not a new epidemic of BPDCN, but as you mentioned, our two groups, you, myself, and others who have helped to raise awareness, we are seeing an increase in uptick in diagnosis. And because of that, we're seeing two new groups of BPDCN. One are more female patients. I believe some of these patients were given a diagnosis, again, not necessarily incorrectly. We didn't know much back then, but AML, leukemia cutis, leukemia NOS, cutaneous T-cell lymphoma. I think that's okay now that we understand BPDCN as a separate entity. And then number two, pediatric and AYA patients. So I believe, Professor Moti, that some of these patients, the BPDCN diagnosis wasn't even thought of because childhood ALL, very common disease, very curable, pediatric AML understood. And so now there's a bimodal distribution, maybe perhaps like Hodgkin's and others, where we are seeing an uptick of young pediatric female patients, those with central nervous system, no skin lesions. And believe it or not, it looks like the molecular mutations may be different, among those two groups. So let's put that forward that BPDCN can affect all people, young or old, male or female, but this was not something appreciated even just 7 or 8 years ago. So let's put that out there as a protein changing variable entity.
Superb, superb, wonderful, and fascinating. And I think there's still a lot to discover in this fascinating entity. One quick question from the audience, because we're talking about diagnosis, the role of biopsy, cutaneous biopsy.
Essential. So I'm so glad that one of the viewers asked that. This is not a diagnosis of guessing or art of medicine. It must be confirmed with the tissue biopsy. As they say, tissue is the issue. To that point, I'm so happy that it was brought up. We have been fooled either way, and I want to give the viewers some example of that. So there are situations where the lesions, quote, look like our BPDCN. So the lesions have a certain look, if you'll allow me to say, as a non-dermatologist, non-pathologist. They have like a purple, dark color lesion. They can be maculopapular all the way to a plaque. But the biopsy can surprise you sometimes. On the differential, in addition to the obvious AML, leukemia cutis, T-cell lymphoma, CMML with PDC infiltration, believe it or not, we found everything else under the sun. Fungal infections, Sweets syndrome, paraneoplastic skin manifestations from other tumors, including solid tumors, autoimmune disease, the list goes on and on. So for this erudite audience, a skin lesion is a harbinger often of something else in our field, but it doesn't have to be another cancer. So think about autoimmune, Sweet syndrome, paraneoplastic, etc. That's where the biopsy is essential. Number two principle is serial biopsy may be the situation. We have a lot of patients who end up being BPDCN, but in fact, the initial biopsy either didn't reveal it, patchy, it wasn't thought to send the CD123 stain. So in BPDCN, if you have that suspicion, don't rely on just the one biopsy. You may need a second biopsy, different location. And finally, I think I would also add The other way happens too, meaning that sometimes someone has diagnosed BPDCN on the outside, and then we have overturned it actually to one of the others, given, again, some of these stains and all that. So either way, the elusive entity has to be either double checked, confirmed. Of course, if you have access to expertise with pathology, that helps, but tissue is the issue. Let's say for ourselves here, BPDCN, like AML, like myelofibrosis, really should be biopsy proven.
Excellent. Thank you very much. So let's move on now. We've got it right. We have the diagnosis and we start the treatment. And maybe you can walk us through the history of treatment and why the advent of tagraxofosp, which is a sort of a targeted therapy, and maybe you may wish to explain the mechanism of action of the drug, and then we will look into the data from this paper, which are really interesting.
Yeah, so 3 points to your nice aspect here, which will give us to the paper. So point number one is the reason why we're meeting is this rare disease is a historical poor prognosis. We're talking about 8 to 12 months in all of our series. That's despite getting multi-agent chemotherapy that's been borrowed from, as in this paper, AML, ALL, hybrid therapies, lymphoma, multiple myeloma, even, you name it. We've tried all those regimens over the last 30 years. 8 to 12 months, and the only folks who have survived beyond that were folks who were able to get to transplant, maybe historical, only 10% of the patients available for that. So a historically deadly disease. Number two, these borrowed treatments that I mentioned, which can put the disease into remission, although not at a high rate, almost always what happens is it's a transient remission, if not consolidated with transplant. And then when the BPDCN comes back, in the relapse refractory setting, the expectation is 6 months or less overall survival. So when the disease comes back, it's even more aggressive, more chemo resistant. Almost none of those patients were able to be put back into a CR2. And then the third principle here, as you said, there were no targeted therapies until our group and others found that CD123, some of you know it as IL-3 receptor alpha, is present. It's ubiquitous, 100% of BPDCN cells. Yes, you do see it on the majority of AML and MDS and other myeloid cells, but 100% on BPDCN. And before, there were no targeted therapies. There were some concerns that even though it's surface accessible, perhaps these drugs would result in myelosuppression, et cetera. The advent of the tagraxofosp, or we'll call it TAG, was a breakthrough in our field. It's a novel, clever agent. It's a recombinant IL-3 fused to a modified diphtheria toxin. So it's a bacterial ADC cytotoxin. And because it involves the IL-3, it homes into the IL-3 receptor alpha, which is CD123. And it really leads to surface engagement, endocellular ingestion, and then protein destruction, so apoptotic cell death in the CD123 cells. It represented for the first time the targeted therapy. We did a pilot study of this diphtheria toxin-based drug, TAG, published it in Blood in 2014 with my colleague Art Frankel. That's 11 years ago now. And then nicely, we were able to follow it up with a multi-center prospective clinical trial registrational phase 2 study, which was positive, 90% overall response rate in the front line, and about 60% in the second line setting, a refractory setting. And I'm proud to let people know that that led to US FDA approval, ages 2 and older, in December of 2018, and then also separately EMA approval, January 2021 for adults frontline only. And I think that sets us up for the paper as I turn it back to you, which is those are the two approvals. And so we and others wanted to ask the question, what about in the relapse refractory setting, especially in the real world setting, US versus European, and looking at not only outcomes, but safety, because the drug has to be given in the hospital for the first cycle, and then looking at the capillary leak syndrome. So Professor Mothi, that's kind of the background. I think that gets us to this nice paper you selected for today.
Excellent. So you nailed it very nicely, Naveen. And we have a few questions about the practicalities. How do we administer tagraxofosp? Are there any pre-medication that we need to use? And then we have another question from the audience. Usually cancer drugs are tested single agent and then they are combined. So what about combinations here?
Great. Let's focus on the practical first. This is excellent and is essential for today's program. This is a great question as we expand into Europe, Asia, Africa, the rest of the world. It is at times a difficult drug for some teams to give, and so it requires a little bit of preparation and education. I want to walk you through that. So number one, it's an IV drug, and the US FDA approved and EMA approved dose is the 12 micrograms per kilogram daily dose. It's planned up to 5 doses per cycle in the BPDCN monotherapy, the standard that we're talking about. But I want to emphasize that I've had patients go into remission even with just 2 doses, 2 or 3 doses, because it's such a potent active drug. The reason why that's important is you must monitor daily during infusion doses, albumin levels, fluid status, creatinine, and liver, because that tracks with the toxicity of the drug, which is a vascular or capillary leak syndrome. So IV first cycle must be given in the hospital. We do that ourselves in the US, so we want folks to do that. And then the subsequent cycles based on safety and tolerability can be option of outpatient. Pre-meds are essential with our tagged agent because there are some infusion-related reactions and it can mitigate some of the first dose toxicity. Those are the standard pre-medications that you'll see those on the package label insert, so the Benadryl, Tylenol, steroids, etc. And the last issue I will say is the daily weight and the fluid status is hyper important. You want to keep your patients on the dry side. And if they hit the tripwire of fluid status or albumin, you want to hold the drug because that's what tracks with the capillary leak syndrome. So the kinetic drop in the albumin, the rise in the weight, those are hard points where you can stop for that day, focus on diuresis, whatever you need to do, and then reevaluate the next day. Part two of the question is very important. So the monotherapy, as I mentioned to you, gosh, we're coming on, what would you say, the 7-year anniversary of approval in the United States, 4 or 5 years now in Europe. And you're right, there are at least 2 active ongoing combination studies. In the US, we have the TAG-AZA-VEN study. So that is a triplet. We tested monotherapy, doublet, and then now we're at the triplet in both frontline and relapse refractory BPDCN. So let's await those results. And then also here at MD Anderson with myself, Professor Kantaraj, and our group, the TAG hyper-CVAD-VEN kind of combination there. Again, obviously using all of the active agents in a total therapy approach. Can we eliminate the need for transplant perhaps? Can we eradicate MRD disease? Can we go for functional cures for these patients? So those are the questions that are being asked with the combinatorial approach.
Super, super. The future looks bright. But when I was listening to you about the CLS, it reminded me that the story of capillary leak syndrome, actually, it's a very old one. When I was a medical student and GCSF was launched, actually, there was an alert, be careful of capillary leak syndrome. And, we learned how to manage it. And this is like, I would say, not really a big deal. It's not a life-threatening condition. And obviously, the pathophysiology is quite complex, but this is something at least the transplanters and leukemia doctors are quite familiar with. So now let's look into the results. We have here real-world evidence. This is an early access program in different European countries. We have heavily pretreated, relatively older patient, and despite this, we see an overall response rate in this paper of 65%. So what do you think about this number?
Yeah.
Is it, modest?
Totally.
Is it
No,
good? Is it great? What do you think?
I have to say it beats the historical expectation. So keep in mind, as you mentioned and reminding us, this is a retrospective analysis on what we call a named patient program, or in the US, maybe we call it compassionate, extension program. That's what's remarkable. There was no real inclusion or exclusion criteria. It's a remarkable testament to the European physicians, the treating teams, for what you and I were talking about earlier, the education of the patient, the family, the team, the expectation that that first cycle you're watching for the potentially deadly toxicity of capillary leak syndrome. So there were no new safety signals here. The capillary leak syndrome was handled and managed very expertly. And then, as you say, not only the response rate, but several of these patients, many were actually bridged to a transplant. I think one was a second transplant. So for the team listening here, this exceeded my and our expectations of a relapse refractory program. It's actually heartwarming to see it. Some of the patients you showed had AML-like regimens, ALL, CHOP, a hybrid chemo regimen, prior transplant. So this is actually a fantastic data set, and it allows us to build on expanding the drug throughout the world.
So, Naveen, we insist on this issue of bridging to transplant. Why is it important, although a lot of these patients could achieve CR? So you may think, okay, they are in CR, let's wait and watch. Why is it today? Maybe tomorrow the story will change because you're mentioning some trials trying to have a sort of a
Maybe.
total package of therapy to avoid transplant. Why is transplant, bridging to transplant is important today?
Yeah, I'm glad you mentioned it. So let it be heard here that the gold standard as of today is all patients with BPDCN should be considered for allogeneic transplant in CR1. It is because even though we can achieve high rates of CR with monotherapy or even multi-agent therapy, we have not yet seen a durability of that, and we have not seen patients by and large can be sustained by pharmacologic therapy alone. And so the transplant, if it's available, is your best way to consolidate. I would say number two, interestingly, is that transplant, of course, you and others have pioneered across the world, is becoming more and more accessible. Almost everyone can have a donor now. So yes, we have done haplotransplant in BPDCN. We have done auto transplant, maybe of interest to you and myeloma team. And these are all published. People can find this. That perhaps with the auto transplant, reduced intensity, 9 out of 10 haplo, even though obviously all of us always prefer the full intensity allo, perhaps with BPDCN, almost everyone can have a donor. The auto transplant is of particular interest to you in the myeloma field who pioneered it, which is maybe we've identified an older, unfit, frail patient. Maybe perhaps, Professor Moti, they have skin-only disease, no marrow involvement. Could that be someone that benefits from auto? Our group, the Japanese group by Aoki et al., people have shown that that may be potential. But it looks like in the modern era, transplant is an essential part of the journey. I also wonder, we haven't shown yet, but could there be a GVB effect, graft versus BPDCN effect? I think that's potentially there. And I will tell you, we have sent patients to in less than a CR, so perhaps a PR or some version of a response who have benefited from the transplant. So I do want to emphasize that that's the case. Also, this study that we're talking about points out something interesting. A lot of these patients were ECOG PS of 2. When you look at the paper, as you and I have, they actually improved their performance status after the TAG monotherapy, became 0-1, and then went to a transplant. This dynamic improvement of performance status may not necessarily have been anticipated by standard of care chemo, multi-agent chemo, every other agent. There was a low rate of neutropenic fevers, low rate of myelosuppression with the TAG. So it's kind of cool you ask about it. This is a really fantastic part of giving the TAG that folks are not beat up and they're able to go into a transplant with potential of a long-term success.
Excellent. So the message is clear whenever possible, even if they are in partial response, and this, if it is feasible, they should go to transplant. So we have a question here from the audience about the use of TAG post-transplant for maintenance.
Nice.
Is this something that is common practice? Do we have such experience? I mean, theoretically, I would say personally, yes, but what's the state of the art there?
Yeah, we do want to move in that direction. So we have only published one report on it. Folks will see it. It's this year. It was only one patient that we were able to treat on protocol. So it's like a case report, but a formal protocol. That patient had a successful outcome. High risk patient, some form of MRD positivity after the transplant, and we gave a year's worth of TAG. Patient did extremely well and is doing well several years post-transplant. So that's a victory. However, of course, that's only one patient. The problems theoretically have been that people are worried about toxicity post-transplant, and for good reason, not only LFTs, VOD, GVHD, but also worry for the capillary leak syndrome and others. The other worry is we never defined an MRD and BPDCN together. So right now we're borrowing, and it has worked functionally, from ALL, AML, sort of a flow-based CD123-based MRD. It makes sense because we know how to track that. But that's one thing I want to mention to you, is that we didn't really define an MRD. So who's high risk and who isn't post-transplant? So that's an issue. Number two, we also published a small series out of my group on oral decitabine plus venetoclax. That may be a potentially somewhat of a realistic option as maintenance post-transplant or a pre-transplant for folks. And then there are new CD123 drugs, Professor Mothi, that are being developed. Pivekimab sunirine is one in the later stages of development. That particular drug doesn't have a signal for the capillary leak syndrome, but potentially a few patients with VOD. So you need to kind of weigh these things out, right? Pre and post transplant. So this question is important, but put that on me and our team, which is, I think we need to define, as you've done in myeloma, as folks are trying to do in AML, as they've done in ALL, who is high risk post transplant? What is the MRD measurement? What's the goal of the post transplant maintenance? So if it's eradication of MRD, and then we need to do long term follow up to show that that translates into overall survival clinical benefit. So stay tuned. That's our work for the next decade.
So if we try to summarize the treatment algorithm today, and assuming, of course, TAG is available, because obviously we know that across the globe, situations can be different. And we at the ICH always advocate for availability, accessibility, and affordability of drugs for the benefit of patients. So assuming we have TAG, do you agree with me that this should be offered in the frontline setting, in the relapse setting, and eventually after a transplant? As of today, that should be considered the state of the art, and maybe we should move away from these empirical, toxic, old-fashioned chemo regimens?
Well, it's a great question, because obviously, as all the viewers know here, in these ultra rare diseases, we won't have randomized trials head to head, and these are all apples and oranges therapies. I think, to your nice point, I think I picture a personalized, tailored approach in the coming years. We're not there yet, but we're getting there. For example, one way to think about it is tag eligible and tag ineligible. So to your point, if you're tag eligible, you've seen the data from our New England Journal, 90% overall response rate in the frontline setting, of which 72% is CRP, and then you've seen the data in the relapse setting in this paper and others. But there are patients who can't get tagged frontline, so it's worth me mentioning. Albumin is low, some cardiopulmonary comorbidity or difficulty that may put you at exquisite risk for capillary leak syndrome, et cetera. So perhaps with the caveat of tag eligible, tag ineligible, I have to say cost and availability of the drug may be an issue in some locations. And then the ability to monitor. You do have to have a team, whether it's a PharmD, nursing team, doctor team, who's able to follow these patients on night, weekend, holiday, again, especially if they need albumin infusion, et cetera. I think the other point to mention here is, especially in the States, in America, there is a good debate going. What if you have a young patient, 21-year-old patient, extensive disease, bone marrow, skin, lymph nodes? Would they benefit from the debulking of a hyper CVAD or hyper CVAD ven-based chemo? We've had a lot of success with that as well. Again, you're never going to have a head-to-head there, but you do wonder if there's a group of higher risk patients with bulky disease. And of course, that's where our triplet combination comes in, where we give all of the above, right? So I think that, and then one other principle, there's the central nervous system involvement, right? I wanted to end with that. So these targeted agents, TAG, venetoclax, BCL2, pivekimab, the other CD123. So CD123 and BCL2, we don't believe that they cross the blood-brain barrier. We don't have evidence for that. And so you have to add LPs with all these therapies. One benefit of the hyper CVAD approach, if you will, ALL-based approach, your group and others have also published on these, is that you do have cytotoxic drugs there that cross the blood-brain barrier, so that may help. So may I say, for 2026, as we enter that year, yes to everything you said, but I wonder if that's the argument for combinatorial therapy, that each aspect gives you something different. Hyper CVAD gives you blood-brain barrier, Ven gives you BCL2 blockade, TAG, PVEC gives you CD123. You just got me super excited. I think that's the solution, what you just said.
Fantastic. That brings us to this concept of total therapy.
Total therapy, that's it.
It's
What
not
you just
about opposing old or new drugs, is how can I make the best of them and combine them and maybe and we've been doing this in transplant, the sequential conditioning regimen, giving chemo, conditioning, transplant. Why not envisioning something in those high-risk patients you're mentioning? If you have data about hyper CVAD, say hyper CVAD, TAC consolidation, transplant. So really, really fascinating. Well, we're coming to the end of this journal club. So if you allow me, Naveen, let me briefly recap our key messages. I think today's data clearly reinforce the role of tagraxofosp as an active and valuable option in the relapse refractory BPDCN and achieving meaningful response rates and effectively bridging a substantial proportion of patients to allo transplant and doing so with a manageable safety profile, particularly when we are vigilant during the first cycle for capillary leak syndrome. Interestingly, these real-world outcomes are remarkably consistent with the pivotal clinical trials, confirming tagraxofosp as the current standard in this very challenging setting. On behalf of the International Academy for Clinical Hematology, the ICH, I would like to warmly thank our guest, Professor Naveen Pemmaraju, but also all of you in the audience for your active participation and insightful questions. I hope this session will translate into better care for your patient tomorrow, and we look forward to welcoming you to our next ICH educational activity very soon. Wherever you are, please stay safe and keep well, and happy Thanksgiving in the next couple of days. Thank you very much.
Thank you. Bye.